Our next speaker today is Dr. Stuart Rosenberg, who is the CEO of Harvard Medical Faculty Physicians in Boston, and also is the president of the Beth Israel Deaconess Medical Center Provider Organization. He has intimate knowledge of accountable care organizations, and he's here to speak to you on that subject and to help demystify some of the things that you see coming down the pike. Dr. Rosenberg.
Thanks very much, Rob. It's a pleasure to be here in San Diego and to talk to everyone about healthcare reform. We're going to have a conversation this afternoon because this is a topic that's fraught with concern, worry, and confusion. And I'm going to get eventually to what an ACO is and how surgeons might be able to improve their reimbursement under ACO rules. But first of all, I think in order to understand how best to fit in with the new reform, we have to understand how we got there. This didn't just happen overnight. It wasn't just a political solution that someone dreamed up. I'm getting signals here. One afternoon. There's a reason that this has happened. And I think it helps if we think of ourselves as business people and taxpayers, which we all are. I remember the days when we were in medical school before we became cardiologists or surgeons or psychiatrists or obstetricians, and we wanted to be doctors. And we were going to be the senior members of the medical healthcare delivery system. We got that training, and some of us became surgeons, others became other things. And we tend to go into our corners, do what we do very, very well, focus on the patient, door to balloon time less than 90 minutes. Our organization hits it 100% of the time. Our cardiologists are really good. We have great systems. Our surgeons do hip fractures in the elderly superbly. We coordinate with geriatrics, and we really do a good job on repairing elderly people who have broken their hips. We do a lot of things great in the United States, and physicians are very dedicated. I'm one. I don't like the implication that I'm not doing the best for my patient. But when you take a cold, hard look at the system doesn't deliver very well. And we are the senior members of the healthcare delivery system. Remember, the healthcare delivery system is doctors, nurses, hospitals, pharmaceutical companies, device manufacturers, and a few others. That's 5% of the population. We're in that 5%. That's 15 million people or so in the United States make their living. I forgot the insurance companies, by the way. They're in that as well. And 5% of us split up 17% of the GDP. Now, you might say, you could end your talk right there and say, well, what's wrong with 5% of the people getting paid 17% of the GDP? Sounds good to me, as long as you're one of the 5%. Problem is that we're also taxpayers. We either run businesses where we pay Social Security and Medicare payroll taxes for our employees if we're in private practice, or we get a payroll deduction if we're salaried by an organization. And healthcare is one of those items in the payroll deduction. Healthcare costs have been going up. We saw that in the previous slide. We all know that it's been going up. So let's take a look at what value we get in the United States for the money we spend. So now we're just ordinary citizens. We're just taxpayers trying to make it through life, and we have to buy goods and services. And let's see what we get for our money in the United States. In the US, and before we go there, it's important to remember that the goal of the healthcare delivery system, the thing that we're selling, is to improve the health status of the population that we serve. Now, some patients need very complex operations, and some people need to be in the ICU, and they need transplants, all of which is understood. But what we all really want is our health status, total mental and physical functioning at the topmost levels for as long as we can have it until we can't have it anymore and we're dead. So that's what we want, and we spend $2.7 trillion getting it. The other thing is, what value are the American people, us, getting for the healthcare dollars that we spend? Let's comparison shop and see what we're getting. You know, when we compare ourselves to other rich countries, I'm not talking about Bangladesh or Somalia, I'm talking about rich countries. Everyone's struggling with healthcare costs, and they all have good aspects and bad aspects. But a number of them perform very well. I'm talking about countries like Germany, Israel, Australia, New Zealand, France, the Netherlands. Outcomes are pretty good. The citizens of those countries buy health care and they pay a lot of money. And let's see what value we have with regard to those comparisons, comparison shopping. So in the US, we have the shortest wait to see a specialist of any of the rich countries, although Germany is only 1 percentage point behind. The Netherlands is very close. A lot of countries have access to specialists almost as good as the United States, but we're number 1. You get to see a specialist quicker here than anywhere else. We have more MRI machines by far than any other country in the world. We do more MRIs per capita, and they cost more than any other country in the world. Now, the machines themselves are sold at the same price around the world. Toshiba, GE, Siemens, Philips, and so forth make MRI machines. And we're 50% higher on MRIs than the second country, which is Germany. We charge a lot and we do a lot. We do more open heart cases and stent procedures than any other rich country in the world by a factor of 100%. We do 100% more of those procedures. But when you look at the healthcare data, you look at death from myocardial infarction in rich countries, we're number 22 out of 30. Now, we're comparison shopping. What do we get for all of that money that we're spending on cardiac procedures? Our infant mortality is 27 out of 30. Our administrative cost, we're either number 1 or we're number 30, depending upon whether you think administrative costs are good. We're the highest. We spend more on healthcare administration than any other rich countries in the world. Cause of death from diabetes mellitus, we're number 20 out of 30. Cause of death from cancer, we're number 14 out of 30. And what about the cost factor? Remember, it's value, quality of the goods and services over the cost. So we're middle of the pack on outcomes, and a normal delivery compared to Germany. Germany, cost of living is higher in Germany than in the US. Housing costs more. Gasoline costs more, food costs more. Everything in Germany costs more, so we can't say they have low-cost standard of living and they don't have low cost in general. They're a less rich country than us, so compared to Germany, a normal, uncomplicated delivery costs 400% more in the United States. An appendectomy with no complications costs 400% more in the United States than Germany. A hip replacement's 100% more. Average hospital stay is 300% more in cost. And then to top it off, we're the only rich country in the world who rations care on the basis of price. We're the only rich country that says that we do not provide access to basic health care for all of our citizens. Forget illegal aliens if you want for a moment. We don't provide access to basic health care for all of our citizens. And if you get shot and you go to the ED, we do a great job if you get shot. But if you want routine control of your blood pressure, your diabetes, your lipids, to get mammography, to get routine screening, colonoscopy, and you don't have insurance, you're not going to get it in the United States, with a few exceptions where teaching hospitals and so forth and clinics do it for some. So we're the only country that rations basic health care. I'm getting depressed. And we're the docs. And we want people to look up to us as far as problem solvers to get us on track to do better. What could we do better? Well, first of all, we ought to realize what an impact this is to our paychecks and everyone else in the country. Not anyone in this room, as I look around, but the average household, the median household income in the United States is $50,000. There are people in this room probably make $50,000 a month. So 50% of us in the United States, our brothers and sisters in the United States, live in households where the household income is $50,000 a year or less, and the median private insurance for a family is $14,000 a year. That comes from your employer paying some of it and the employee paying some of it. Employee share of healthcare premiums have gone up 47% in the last 5 years from what they were paying. So as the employer shifts it over. So that's coming right out of people's paychecks. When you pay your state income tax, 20 to 40% of the state income tax, if you're in a state where they have state income tax, goes to pay for health care. Remember, Medicaid has to have state funding, and then there's federal funding. In Massachusetts, it's a high percent. Closer to 40% of the state budget goes for health care. In other states, it's only 20%, but it's a big number. And then we come to Medicare. It's also a big deduction on all of our income. That doesn't come close. All of that deduction, all that payroll deduction doesn't come close to paying for Medicare costs in any given year, much less is it a savings account. So all that deduction's going for health care. Social Security doesn't. And then we have our deduction for our health insurance. So it's an enormous burden on the average family. And the big reason we have to ration care is because the cost per capita for the care we do provide is so high and the value is so low. It's actually helpful for me to stand up here and say this to a group of physicians. I mean, I feel better. Look yourself in the mirror, and this is the way it is. We don't get good value for the healthcare dollars we spend in the United States, notwithstanding the miracles that occur every day, notwithstanding as I look at the dedicated professionals here who work hard every day on their patients. The problem is doing a procedure is not a system of care, and that's what we don't do well. We don't coordinate the care. There's too much waste. The estimate is that it's 20 to 30% too much cost, and that it could be gotten out. And I look at myself, well, I don't know how to get 20% of the cost out. It's not me, and that's the problem. It's not anyone in this room doing any particular thing. It's the fact that we have gotten ourselves fragmented into our little spheres, and no one is looking after the patient as a whole. No one is saying, it's my job to be sure that Mrs. Jones enjoys excellent health status, whether it has to do with her hip, her arthritis, her GI tract, her ulcer, whatever it is. Who is coordinating all that? I said, well, we don't do that here in the United States. Everyone just does their thing. And if you're a student of process and systems, you realize that maximizing the performance of each little process in a long continuum of processes and just looking at each one individually, you always end up with bad performance, and that's what we do. So then the question is, well, it's not my responsibility, it's not your responsibility, who's going to fix this? And by the way, a lot of people say, well, no one can fix it. I don't believe there really is 20% waste in the U.S. healthcare system. And the answer is, people have gotten the waste out, and let me tell you the story about Ken Coburn in Philadelphia. Ken is an internist, and he has run a demonstration project for CMS for a decade. It started out with 55 people in the 55 groups in the demonstration project. They all fell by the wayside except for Ken and his system. And when I heard this, I said, I'd like to meet Ken Coburn and find out what he's doing. So let me tell you, it's a little bit of an experiment. He takes the frail elderly Medicare patients, 5% of Medicare patients consume 50% of the Medicare expenditures. 5% consume 50% of the dollars. So Ken focuses on those 5%. He does a randomized controlled trial in suburban Philadelphia where the primary care physicians don't know particularly which patients are in the control group and which are not. They kind of know because Ken's nurses speak to the doctor. And the data is completely controlled by CMS and government actuaries. Ken doesn't get to see any of the data. He just manages the care, doing what he does with his nurses. At the end of the study period, the active group compared to the control had an overall reduction in expenses to CMS of 37%. 37% of the costs were eliminated to CMS. Compared to the control group, there was a 25% lower overall mortality. Patients were happy with that. The net savings, in other words, Ken's program costs money. So the overall savings 36, 37%, net savings 28% on the highest pay. He's doing it today. I've gotten to know Ken very, very well, and he's doing it today. And I began to tell him about how we do great work with total hips in the elderly, and how we have care managers and coordination of care. Boy, when those frail elderly come in, we do a great job. And look at our cost, and look at our follow-up. Ken said he was really impressed. He said, but do you know how much money you would save if they never broke their hip? I said, well, yeah. I mean, you'd save a lot. You know how happy the little old ladies would be that they didn't have a broken hip? I said, yeah, they'd be pretty happy. But that's what we do. The number of fractures is down something 32, 33%. They just don't break their hip. And of course, our orthopedic friends, no one is in charge of being sure that little old ladies don't break their hips. That's not what we do as physicians. That's what a system needs to do. So I could go on, but I think you get the drift. The question is, what is an accountable care organization? How did we get one? And why is it so politically charged? And how do we participate as specialists in an accountable care organization? So an ACO is a federal program that was in the Affordable Care Act. My organization is one of the pioneer ACOs. There were 32 in the country. We're one of them. We have 32,000 Medicare lives that we are responsible for. And the reason they set up ACOs is because of all the things I just told you. The costs are through the roof. And there was something called Medicare Advantage. These were Medicare HMOs. Some of you probably know about them and participate in systems that have a Medicare HMO plan. But the patient has to sign up for that. The first time we tried it, there was a lot of backlash. And insurance companies make far too much money off of Medicare Advantage plans. It costs more than fee-for-service Medicare. So it wasn't working so well. So the ACO was a response to what we just talked about, and it aggregates patients who are fee-for-service Medicare into a group based on who they sought care from over the last 3 years. The patients don't really sign up. They're attributed to a network of doctors, primary care physicians, surgeons, cardiologists, psychiatrists, big network of doctors. Sometimes there are hospitals involved. And we do the best we can to reduce the cost of care. If at the end of the year the budget for those 32,000 people is less than was anticipated, it was set based on historical norms. If it's less, there's some sharing with the physician group or the hospital group or whoever you put together as your accountable care group. In subsequent years, if you spend more than the budget, you're going to have to pay some of it back. And this is the thing. In order to do what Ken Coburn is doing, seeing that little old ladies don't break their hips, that congestive heart failure patients don't keep getting readmitted over and over, and diabetics are taken care of. It's a limited number of diseases where we're really wasting a lot of money. You have to take the budget. That's what my organization did. You have to take the budget, because you say, but all that waste is based into the budget. If I'm going to work at reducing the waste, I want to be able to participate in some of the savings. And you can only participate in the savings if you take a global budget contract. Now, how does this affect? I have 55 seconds left to tell surgeons how to participate, and it's really quite easy. We go back to taking good care of our patients. We coordinate care. We communicate with primary care physicians and other providers. It's not just the PCPs versus the specialists. We're all in this together. And specialists can coordinate, depending upon what your specialty is, should coordinate with their hospital or ambulatory surgical unit or whatever grouping that you come up with, and say, we want to be a part of taking care of a group of patients that we know best how to take care of. And if you take a global budget for those patients, after you have figured out what the waste is from the lack of coordination, you'd be amazed at how you are able to take on that risk, provide better care for a group of patients, and still do financially well. Remember, changing the payment methodology doesn't change the number of people with certain diseases. That's not going to go away. And the other thing to remember is that the above average physicians, that's getting us to 50%, have absolutely nothing to worry about. I can think of no specialty that is going to go away. The best doctors are going to rise to the top. They're going to coordinate, and it's fun again. You get to think about your patients and coordinating care. You don't have to worry about how many procedures did I do today to see what I'm getting paid. So that's what an accountable care organization is about, an ACO. They're commercial contracts that also have global budgets. And the reason I keep talking about the global budget is that you can't interpose the nurses and care coordinators into the system if we all just retreat back to our offices and say, I just want a fee for service for the thing that I do. And everyone just takes a fee for service. There's not going to be any money to pay for the care coordination. So we're going to have to work together. It's not a bad thing. And I think we can all be very, very successful. So I'm going to stop there and see if there are any questions.
Dr. Rosenberg could take a question or two now, or you could save them for later. Yep.
Hi, I'm Pascal Fuchschuh. I work for Kaiser, so I'm very attuned to what you're saying. But I also have very good friends in Germany that are surgeons. They see on average 60 to 100 patients a day, and they make about a third on average what we make here as surgeons. With this, what you're saying, and with your emphasis on the fact that it's not going to affect us, it's hard to believe for me that that's true. Somebody's going to have to, cap the slack. I mean, we're already in the integrated organization that I work in the last 10 years, efficiency has gone up 20%. In other words, I'm working 20% more, see 20% more patients for the same income. So how are we going to absorb all that? Do you have an answer?
So he wants to know, let me rephrase your question. Volume increasing with quality, and how are we going to absorb all that additional volume?
In this specialty or any specialty?
Any specialty.
Yeah, I'm sorry, I don't hear well anyway, so I apologize. Volume, when we talk about coordination of care, there's a lot of talk that we need a lot more primary care physicians. And the thing is that primary care is not unlike a lot of other specialties. They're working very inefficiently. And the volume can be taken care of if we redesign the way we take care of patients. What we find out that we need when you talk to Ken Coburn is nurses and other professionals to coordinate the care, not so much that we need more physicians in any one specialty, nor do we particularly need more primary care docs. We do need some more primary care physicians, but it's not as much as you would think. If you redesign the way we coordinate care, things work, the numbers work.
We have a text question for you. Is the change in our clinical model from reactionary to preventative care going to be less expensive or more expensive?
And it's a two-way street. It's more or less that you have to spend money to save money. The things that you have to do first are the things that I mentioned with Ken Coburn. You're going to have to create some headroom on some immediate savings. I mean, you could run this thing off the rails, because you're going to have, all of us know that we have to meet a budget year after year, week after week, we have payroll and whatever. So you're going to have to attack the waste, and you're going to have to get the global budget on your side to get that. Preventive care has a longer term payoff. And there are going to be some areas that you're going to, compared to today, you're going to be spending more. In other areas, total, you're going to be spending less. Admissions to hospitals for congestive heart failure are going to go down. Other things, visits to outpatient facilities are going to go up. I mean, so it's going to be quite variable.
Thank you very much.